Hello, everybody, and welcome to Oncology for the Inquisitive Mind, the podcast that aims to discuss, dissect, and demystify the confusing and always fascinating word of oncology and cancer treatment. My name's Michael Fernando, and I'm joined, as always, by my opposite in so many ways, Joshua Hurwitz. How you doing, Josh?
I am doing most fantastically. Thank you for asking. And I'm very excited for this week's episode and the topic.
Yes, the topic is a special area of interest for Josh. It's actually what he's going to be doing his fellowship on in part next year, so we're all very excited for him. Little plug there for you, Josh.
Yeah, thanks, Mikey. That's like a spoiler alert. But yes, I will be doing a fellowship in breast and prostate cancer in 2023.
Yeah, and given that we've already done prostate cancer, the more regular of our listeners will be able to ensure that this week's topic is breast cancer. But breast cancer, I guess, is today we're going to be looking at a very small part of breast cancer, or not a small part, but a significant part. But breast cancer is such a huge topic, Josh, that there is just
It's very, very
there is
complex.
absolutely no way that we could do it any form of justice or anything closely resembling to justice with one podcast, unless that podcast was to go for like 5 hours.
And even then, it would literally be on hormone receptor-positive breast cancer, and there would be 40 other different subtypes. And look, it's a course in itself. Let's be really honest. And breast cancer is again one of those cancers with so many treatment options and so many subtypes and specialties that to be able to be a master of it takes many years.
Yeah, I mean, there's a reason that there are several oncologists that I know of that literally only do breast cancer, and yet they never are short on patients or people seeking their advice.
So very true.
Yeah, and I guess the reason for this, and this is how's that for a segue into my little blurb there. The reason for this is that breast cancer, as anyone who's ever watched the news or been to a fun run or any such event knows, is the most frequently diagnosed and second highest cause of death in women worldwide. Um, and according to one study that I was reading the other day, 90%, up to 90% of patients are diagnosed with early stage disease, which I thought was quite high, Josh.
Michael's fun facts for the day. Yeah, it's really interesting that 90% are early stage disease. Here's a question for you. Why is it that most women with breast cancer are diagnosed early?
Well, I guess it's probably comes down to number one, the awareness of it. Like, I'm sure that most people will know of a family member or a friend or someone that they know of who has had breast cancer. The other thing as well is that it is one of those cancers that, unlike, say, lung cancer or particularly something like pancreatic cancer, which can lie indolent, and it's probably a consequence of its status in the public imagination, is that breast cancer is due to screening programs, access to ultrasounds and mammograms, breast screen, as well as the importance placed amongst women with from a very early age on self-examination, that sort of thing. It is the sort of thing that can be, and very frequently is, caught early.
Yeah, you're 100% right. The screening programs that have been enacted in the last, I guess, 30 years, we could probably say, have saved millions of lives. And it really comes down to the old saying that if you catch this stuff early, it is very curable. If you don't, then it's a different story. But the screening programs and self detection and the fun runs, and in Australia, the McGrath Foundation is one of those really big fundraisers, or anything pink, right? Anything pink is going to probably represent at least some form of breast cancer sort of awareness. It's a fantastic public health initiative that has shown massive improvements. And these days, we no longer see, well, we rarely see fungating masses in breasts and those sorts of things because we catch them so early.
Yeah, definitely. And I guess the other thing as well, just purely from an anatomical point of view, is that it is practical and easy to sort of self-detect and self-examine. I mean, there's no way to self-detect or self-examine for a lung cancer or a pancreas cancer outside of a CT scanner, which carries its own problems.
Yeah, exactly. And speaking to many of my patients, the ones that do get mammograms and ultrasounds, I think it is important to acknowledge that these are not comfortable tests. And we all hope that in the coming years, there will be better detection methods that won't include, significant, really, it's mild trauma and a fair bit of pain to having to do usually every year or every second year, depending on where you are in your life and risk factors, etc.
Yeah, of course. And I guess it's also worth acknowledging the elephant in the room that we are two men, and so a lot of the things that we say will be particularly like things like how obviously uncomfortable screening tests are. These are secondhand accounts, but we will aim to capture the plight, I guess, of the early breast cancer patient.
Very true.
Hmm. So, I guess the flip side of this, and this is something that I guess we could only really say in the oncology space for testicular cancer. It's the only other cancer I can think of that carries this particular um, recognition. Is that, and this is a line that I say to my patients all the time, is that the majority of women with early breast cancer are cured, which again comes down to all of the research screening programs catching it early. It's a fantastic sort of achievement, but when people are women are understandably anxious about being diagnosed with breast cancer, I find that that's an important um, fact to mention and impress on them, is that this is not the death sentence that it once was, and many other types of cancer are.
Yeah, that's really true. But maybe it's also a lot of the women who are diagnosed early also are motivated and seek treatment and have good engagement with their healthcare professionals, especially their general practitioners, and this leads to these one. Well, it's a wonderful outcome. Getting cancer of any type is terrible, but being cured of it and being able to spread the word and educate is really powerful.
Yeah, absolutely. So what we'll be talking today, as I said, we'll be breaking this subject down into I don't even know how many, probably at least six, I would think, topics, Josh, or six episodes spread over the course of a certain period of time.
At least six. There's going to be. It depends how long we gas bag for, but yeah, at least
Yeah,
six.
yeah. So between 6 and 100, I think. And today we'll be talking about the most common type of early breast cancer, which is hormone receptor positive. So very, very briefly, there are three uh, subtypes of breast cancer, and this is really what determines the majority of our treatment. There's hormone receptor or estrogen and progesterone positive. Receptor positive breast cancer. There's HER2 positive breast cancer, which obviously it has its own sort of garden bed of research. And then there's triple negative breast cancer, where none of those three markers are positive. And we can get into the subtleties of what constitutes, HER2 positivity and all of that in later episodes. But this week we're going to be focusing purely on early ER/PR, because Americans have vendetta against the letter O, positive breast cancer.
That's right. Do you have a bit of a case for us to start the conversation, Michael?
Yeah, well, I mean, a case that I think will be relevant to both of our studies that we're talking about today, Josh, and it's the sort of case that I guess sticks in many people's memories when they deal with breast cancer a lot, which is the case of the young breast cancer patient. So, like we've been saying, a woman in her 30s, we'll call her 38, she's premenopausal, which, as Josh will illuminate, has significant impacts on treatment, has completed her family, but presents with a self-detected lump in her right breast, and she's also got a lump that is suspicious in her axilla. She is undergoes a biopsy and is found to have ER/PR positive, HER2 negative breast cancer with a number of high risk features, which we'll sort of litter our episode today with. And she comes to the surgeons first. She has an operation. She's found to have a very high risk cancer in terms of a high grade, high mitotic replication index, high risk features such as lymphovascular invasion, so invasion sort of out into the associated vasculature, with positive lymph nodes. I will say she has 3.
Okay, 3. Yeah, that's good to know. And I think the fact you've said 38 is also a bit. It's going to be a bit challenging, but it's good for our discussion points because age is very important. Although this isn't part of the conversation, I might ask: did this lady end up getting chemotherapy as part of the
Well,
adjuvant treatment?
yes, no, absolutely, she did, and that was going to be sort of the chemotherapy proportion of this topic. I guess is fairly set in stone, and there's only a little bit of nuance, which is why we aren't focusing on it. But she had chemotherapy with 4 cycles of dose dense AC, which is doxorubicin and cyclophosphamide, and then 12 weeks of paclitaxel. So a marathon chemo run, and I do describe it to my patients as running a marathon because it's very much an endurance race and a test of their endurance. In terms of chemotherapy, just to go off topic very briefly, had she been slightly lower risk, or had a low risk cancer but was very keen on the idea of chemotherapy, an alternative is docetaxel cyclophosphamide, or TC, which is 4 cycles every 3 weeks, as opposed to what is it, about 6 months of treatment in total.
Yeah, it's 5 or 6 months, I think, and that's if you have no delays and you manage to get through it all in a timely manner.
Which is very much something that doesn't happen all the time. Um, but certainly for a patient like this who is young, so you've got a lot of time that you want to, I guess, quote unquote, make up, in that you don't want her to recur and die young. So she has a lot to gain from aggressive treatment, lots of high risk features and positive lymph nodes. You would hit her pretty hard. You'd give her ACT, provided, of course, she consented. And so she's completed her chemo. She's come through it pretty well. Let's sprinkle in, she might have had a bit of radiotherapy after a surgery as well. And she comes to you for discussion of the next step, which Josh I think is where he's going to talk about soft and text.
I will talk about soft and text.
Try and demystify it as well, because it's a very confusing set of studies.
Yeah, this is one of those trials when we were talking about what to present, and I was like, I'll do soft and text. I'm like, I remember this trial. It's pages long, and there are so many variables in this, and the conclusion is a difficult one. Correct me if maybe you've come to a great, easy conclusion on how to manage this, but I, for one, having reread it and gone through it and done a fair bit of breast cancer, I still find it difficult to create what is best for the patient, risk factor averse, and potential future risks averse, especially in a 38-year-old, right?
Yeah, absolutely. And I think it's very much like that. It's something that's thrown around, Josh. I'm sure you found this, according to soft or according to text. And yet a lot of people seem to have different takeaways from it.
Well, that's the problem, because there were so many things looked at in this trial. You can honestly take away and advocate for whatever you believe in, but I think unless you're following up this 38-year-old lady for the next 30 years and able to adequately manage the potential complications, it's really an open disclosure and discussion with what the patient wants and what they're willing to tolerate. So, a little bit of a context. Michael's already done a wonderful thing of introducing it, but realistically, patients who are less than 35 years of age, who are hormone receptor positive and retaining estrogen production, are at a higher risk of recurrence than those who are over the age of 35. That's the blanket, right? Um, Someone who's 36, still probably high risk, but that's kind of the line in the sand that we draw. But that varies. So
Sorry, Josh, was there a reason they sort of, I guess, came to 35? And is it a bit of a, you might not be able to answer this, but is it sort of a bit of a continuum? Like, does your risk sort of continuously drop after 35, or how do they come to that?
honestly, have no idea. That's a good way to answer the podcast. But I assume assumptions are bad, but I assume that it's to do with the fact that the older you get, the less hormones that you produce, and therefore the less risk. And maybe there's evidence to back it, but I think someone who's 38 who's still premenopausal, then you could really justify that conversation and say you are still high risk, in my opinion, because of A, B, and C. But did not answer your question particularly well. But I think if you just remember 35, it's a good cutoff to kind of be like anyone, I would say within 5 years of either direction, you can essentially say you're potentially high risk. Let's really talk about this in further detail. I kind of cheated, I have to admit. This trial has been around for a while and there are quite a few updates. So this is for the one from New England Journal of Medicine from 2018, which is really the 8 and 9 year update. So imagine this. This trial started to recruit, I think it was 2003, and it is still exceptionally relevant. And it is a fantastic trial because they've done so much. The overall impression from the 5 year update, it's like, those movies where you see the end of the movie in the first three like minutes. This is what it's like. So
Yeah.
in the suppression of ovarian function trial, so that's the soft part, SOFT, and the tamoxifen and exemestane trial, which is the TEXT component, I will refer to these as soft and TEX. The 5-year recurrence rate of breast cancer was lower in the premenopausal cohort of breast cancer patients who received an AI, so aromatase inhibitor exemestane, plus ovarian suppression, so putting your ovaries to sleep and not producing estrogen, than those that received tamoxifen and ovarian suppression alone. Right. So ovarian suppression added to tamoxifen did not significantly lower recurrence rates than those with tamoxifen alone. All right. So that's kind of the history of it. Now, looking a little bit at the background on why they did this trial. So adjuvant treatment with tamoxifen for 5 years reduces recurrence rates of premenopausal estrogen receptor positive breast cancer, right? They know that up to 15 years and potentially longer. Extending duration of tamoxifen for 10 years improves outcomes. But the question that they had is that the effect on ovarian suppression has been less certain, right? They weren't sure at this point, and that's why they've kind of done this trial. So it was 2003. The soft and text trials were kind of thought they were premenopausal women, hormone receptor positive. The question soft had was to determine the value of ovarian suppression to tamoxifen and determine the role of exemestane plus ovarian suppression. The text was determining the value of exemestane compared to tamoxifen in women treated with ovarian suppression. So similar, but different, right? I've already spoken about the 5-year update, so I'll just skip over that. So the methodology, they were premenopausal, they were operable breast cancers, they had at least a hormone receptor, so ERPR positive percentage of 10%, so that's something important, and chemotherapy was optional. But this is important because when you look at your conclusion, and again, this is a bit of a spoiler alert, people who had chemotherapy had a higher risk of recurrence, and therefore the question in that cohort of patients was A, should you give the exemestane and ovarian suppression versus not? But then again, they're also a higher risk in themselves, right? So it's a bit of a mind twister, I feel.
You've got
So
to
the
stop.
soft
You've got to stop spoiling the study, Josh, before you get into the
I,
meat of it. All of our listeners will switch off.
I know, that's okay, guys. It's already been 18 minutes, so let's be honest. You probably have. No, kidding. So soft trial, 3,000 patients approximately, randomized 1:1:1. So either tamoxifen plus ovarian suppression, or exemestane plus ovarian suppression. They're the three arms. It's difficult. You will probably have maybe you have to look at the trial, but I had to read this a couple of times when I first looked at it. Then you've got the text trial, so about 2,500 in this one. It was randomized 1:1 to receive exemestane plus ovarian suppression or tamoxifen plus ovarian suppression. The endpoints, Michael, what do you think the endpoints were? Let's make this interactive.
Interactive. God, that's a word that causes anyone listening to a lecture to sit up in dread. I would say the endpoints would be invasive disease-free recurrence, looking at
Yeah,
sort
pretty
of
much.
recurrence rates, because as we'll see with a lot of studies in this area, overall survival, they probably have overall survival data now because it's been going on for so long, but it does take many years in these patients to get enough events for overall survival to actually be mature.
Yeah, exactly. So primary endpoint was disease-free survival. So what that means is recurrence, local, regional, or distant, non-breast invasive cancers, that sort of stuff. Secondary endpoints was the endpoint was interval without breast cancer, right? So time from randomization to recurrence. So slightly different and slightly different endpoint, but it's important to note. The median age was in their 40s. There was probably not a huge percentage of people below the age of 35. Maybe in the chemotherapy arm in the soft text was about 20%, and in the text arm was about 11%, right? Most people kind of sat in that 40 to 49 age bracket. Most There was a variety of people that had lymph node positive and lymph node negative, as expected when you divide it by chemotherapy. Those that were lymph node positive received chemotherapy. Those that were lymph node negative were more likely not to receive chemotherapy. But there are a lot of nuances to do with size of tumor, as Michael said, LVI, all that sort of stuff. They also looked at HER2 status, which is another conversation on itself. So efficacy, disease-free survival after 8 years. This is the meat. So 83.2% in those in tamoxifen plus ovarian suppression, right? So that was a hazard ratio of 0.76. It was 78.9% in those in tamoxifen alone, and a whopping 85.9% in those in exemestane plus ovarian suppression, with a hazard ratio of 0.65. These were all statistically significant. When you look at recurrence, okay, so they found that this was more likely in those that had received chemotherapy, and I briefly mentioned that before. So the 8-year disease-free survival was 71.4% in the tamoxifen arm, 76.7% in the tamoxifen and ovarian suppression, and 80% among those with exemestane plus ovarian suppression. So, Michael, like you were going to say something?
Well, I was just going to ask, Josh. So you've mentioned it a couple of times. This phenomenon of patients who receive chemotherapy being at higher risk. Is that's not linked to the chemotherapy though? That's sort of an artifact of chemotherapy being a surrogate for patients just having higher risk disease. Is that
Oh,
fair to say?
absolutely. So, yeah, so what this means is that when people get stratified and presented at MDTs, is patients at a higher risk of recurrence in the context of surgery, they are going to receive chemotherapy to reduce that risk. Those that are low risk are less likely to have to go on to chemotherapy because it's a risk benefit analysis. And there's lots of, what's it called? It's been a while, but the UK Predict is one of those really great tools that you can actually look at the benefit of having chemotherapy in a breast cancer perspective. And I'm pretty sure it's not all breast cancers, but it's a subtype. And you can actually look and see, if I give this patient adjuvant chemotherapy, what is the chance that I'm actually going to reduce the risk of my cancer coming back? Because that's what you want. Everything else is irrelevant. Well, you don't want toxicities, but everything else is irrelevant. You want to live longer, especially if you're in your 40s. You might have kids, you might have a full work life, you might be traveling the world. You don't want to be seeing an oncologist every 6 months or whatever the rest of your life is. You want to be cured and go about your day. That's what I mean by when they're higher risk. And this is why it becomes a little bit complicated when how are you going to suppress or how are you going to actually treat these people. You then move on to the recurrence, right? So recurrence of breast cancer with a distant site was reported in 300 patients in the 3000, or about 10% in the soft trial. Adding ovarian suppression to tamoxifen didn't result in a significantly lower rate of distant recurrence than those with tamoxifen alone, right? So it was not statistically significant, although it was trending towards benefit, right? Then the rate of distant recurrences was low along patients assigned to receive exemestane plus ovarian suppression among those who then tamoxifen alone. So important to note in this arm, it was the two intervention arms against really the control arm, which was tamoxifen alone. But the hazard ratio for exemestane and ovarian suppression was 0.73, and that was statistically significant, right? So 8 years of freedom from distant recurrence cohort was 80% in those in the tamoxifen, 82.1 in those in the tamoxifen plus OS. I'm going to say that for ovarian suppression, and then 84.5% in those assigned to receive exemestane plus ovarian suppression. Michael has his hands up, although you guys can't see it. I would love to hear what you have to say.
I guess the main thing that I wanted to say is when you look at the numbers, they're quite small. So even though we're saying, hey, hazard ratio of 0.65, it's a difference of 4%. And, 4% isn't nothing, of course, but it's not the huge, sea change of treatment, which I guess is a feature in many of these studies because we're already really good at treating early breast cancer, so we are sort of eking out the last few percentage points. But that obviously comes into the risk versus benefit
It really does, and
calculation.
I think this is why a lot of the specialists I'm not going to say a torn, but they all have a slightly different take on this trial because
Mm.
of these numbers, right? So if you look at the overall survival at 8 years in the tamoxifen plus ovarian suppression, it was 93.3%. Ridiculously, that is a fantastic outcome, right? And then if you look at the overall survival and those in XMS stain, it was only 92.1%, right? So slightly lower, but still fantastic. And these are both versus tamoxifen. And it becomes a little bit more complicated when you combine the two trials and you look at the outcomes, but that's sort of what we're at right now. I'm going to skip a little bit about the efficacy, but they're all very efficacious, right? When you look at recurrence and you combine it, the 8 year freedom from distant recurrence was 91.8% in the exemestane plus ovarian and 89.7% in those with tamoxifen, right? A difference of 2.1 percentage points. So, like, it's not groundbreaking 2%, but to that 2%, it is groundbreaking. I think that's something that's really important.
2% becomes 100% for those people.
Exactly. But then let's talk about adverse events. It's the dramatic pause. But in the adverse events, Michael,
I
I'm
thought
terrible. I don't,
I thought you just frozen there for a second.
no, I just wanted to dramatically like engage people. There are quite a few adverse events. Interesting enough, any adverse events in the tamoxifen arm, 95%, 98.7 in the tamoxifen and ovarian suppression, and then 98.7, so identical in the exemestane plus ovarian suppression. There's a lot of side effects, and some people you talk to will have these, some people will have none. It's unfortunate. I think at least 10 to 20% plus will have at least mild side effects, probably more. Um, and from just aromatase inhibitors and tamoxifen, things you think about: body aches, muscle aches, vaginal dryness in the aromatase inhibitor arm, risk of things like thrombosis, clots, PEs in the leg, PEs, DVTs in the leg. So looking at the actual numbers in thrombosis, so these are clots, 2.2% in the tamoxifen, 2.3% in tamoxifen and OS, ovarian suppression, and 1.2% in the exemestane. Slightly lower, that's good, but also it's an aromatase inhibitor, so you'd probably expect that. In the musculoskeletal symptoms, which can be significantly debilitating, 6.7% in the tamoxifen. These are grade 3 or grade 4 adverse events, guys. These aren't grade 1 or 2. 5.7% in the combination of tamoxifen and OS, and then 11.4% in the exemestane and ovarian suppression. So if you've got a 35-year-old woman who, say she's a full-time pharmacist, she's got 2 kids, she's running around, this could be a deal breaker, right? You're like, sure, I can't live my life, and I'm expected to be on this for 5, potentially longer, because that's what that's one of the questions they ask: how long? And then this is something I've seen and that I think we still need to do a lot more research in, is the osteoporosis component. So 3.9% in the tamoxifen, which is a bit ironic considering it promotes estrogen. But that's what they've said. 7.2% in the tamoxifen and ovarian suppression, and 14.8% in the exemestane and ovarian suppression. So you've got that 35-year-old pharmacist. Sorry, Mark, you said 38. 38-year-old pharmacist, 2 kids, busy. It becomes more difficult, I think. Michael, what do you think?
I think that is. I completely agree with everything you've said, Josh. As usual,
Oh, stop
the
it. I'll keep you around.
can definitely stay. Um, the I think that a lot of the things that we focus on the side effects of AI and tamoxifen, not without reason. But the ovarian suppression can cause significant issues too. I've had a number of women who say that the actual delivery, because it's a implant that's injected subcutaneously every month, every 4 weeks, and the implant itself can be quite painful. But effectively, because it's ovarian suppression, it's exactly what it says on the tin. You're putting these women through menopause, and we do it for a reason. There's a benefit in high risk patients, and also, we've said in this in with this patient that they say they've completed their family, which is a critical question to ask, but she has the right to change her mind, and in a year's time she might want additional children. And the best way, given that she's had chemotherapy, which is toxic to the ovaries, and is due to have sort of the maximal therapy, which is an AI, which requires sort of ovarian suppression postmenopausal state. Um, the best way for her to potentially come back and have kids down the road, and pregnancy in breast cancer is yet another completely whole topic, and it's very, very complex. But if you
Very
want to
complex.
but if you want to protect her ovaries, give her that chance, the opportunity to change her mind, then you do need to push her through menopause. But menopause, as a lot of women will say, and again, coming from a man, and a man who is much younger than the quote unquote menopausal age. A lot of women will tell you that menopause is awful as well, and so you do have these side effects. But coming to the osteoporosis question, Josh, and again, we won't go through this in depth, but subsequent to this, there has been this concept of adjuvant bisphosphonates for high risk breast cancer, and there was a meta analysis that showed that it had a benefit in high risk postmenopausal women, and so I think we do apply it to women who are on Zoladex, or if it had a bilateral oophorectomy. So that one will hopefully minimize the risk of osteoporotic events, but also has an anti-cancer effect. So in very brief, it's 3 years of 6 monthly zoledronic acid, and it seems to work. But I guess that's one thing that hopefully we will see less of, is these young women with horrible osteoporosis, just because we're preventing it up front.
Sorry, I did forget to mention that, so thank you for bringing it up. I still think in this space, we have to see what the 15-year and 20-year outcomes are, which we don't have at the moment. Because adding to, yes, you can give the adjuvant bisphosphonate, yeah, it has benefits, but the question is, does it last long enough? If they end up getting osteoporosis early, we do have a number of really effective treatments for bone strength, but eventually they have to have treatment breaks. They might have minimal trauma fractures. There are risks involved and potential toxicities from those drugs as well. So yeah, they do give it, and yes, there are benefits, but also I think there are still unanswered questions in this field.
Yeah, I think that's very fair.
And one last thing I wanted to talk about before I hand over, I am aware of the time. So there was also looking at efficacy. Um, and efficacy, they combined the soft and text protocol together. And what they found is that the ear disease survival rate was 86.6% among those with exemestane plus OS, 82.8% in those in tamoxifen plus OS, and that was a difference of 4%. And we were talking about this percentage. But in saying that, we do give people chemotherapy with lower overall survival benefits, right? But we have to take into account in this cohort of patients that they're young, they have hopefully a lot longer of their life to live. So they have potentially 40, 50, 60 years to go. And they probably live very active lives. That means we need to try and promote their quality of life whilst reducing their risk of having this cancer recur. But it is an interesting topic. And this was really, I think, the start of a big conversation about minimizing cancer occurrence in these females, but also looking at toxicities. But I know you're all wanting Michael to talk about his trial. So why don't we switch over, and then we can potentially have a bit of discussion of what we would do in this 38-year-old pharmacist with 2 kids.
Yeah, I love that you've added the 2 kids and the fact that she's a pharmacist, Josh. Um, so so the study I'm going to look at. So we know in theory what the optimal treatment for this patient would be, and that would be post chemo, post radio, a AI with ovarian function suppression, and obviously we're making the assumption that she's willing to go along with it. But I guess the follow up question is that she is very, very high risk. She has 3 positive lymph nodes. She has a grade 3 tumor, a high Ki67, which is a marker of cell turnover and replication. So a high percentage means that the cancer is replicating and dividing faster. And even though we're looking at survival rates at 8 years in excess of 80%, there is still a risk of disease. And as we say, these are young patients, and we do try and eke every percentage point out. So in the metastatic setting, there is a class of drugs called CDK4/6 inhibitors. And what they really are, and it's funny, I've had this metaphor told to me independently by two separate oncologists who have never met each other. But the way they are described is Batman and Robin in their combination with AI. So Batman is the AI, does all of the work, or the majority of the work, and the CDK4/6 is Robin. It's a little additive that aims to improve things, but really can't stand on its own. It's not Nightwing yet, for all of you comic book fans out there. There are a number of agents, and they all end in cyclib. So palbociclib and ribociclib are the two most commonly used, but monarchy is of a third one called
Forgot about one. There we go.
abemaciclib, which I was just about to say, Josh, before you
I
jumped in.
wanted to interrupt you. So
You just couldn't help yourself. I could see your finger hovering over the mute button on your microphone.
I was lost in your Batman analogy. I was just entranced. It's great.
Furiously Googling to find out what the hell I was talking about. So the rationale of this study, Monarch E, that's Monarch -E, is that 20% of patients have recurrence of disease even following curative treatment. And there's this phenomenon in particularly hormone receptor positive breast cancer that these recurrences can be quite remote, and we're talking 10, 15 years plus. I think the the oldest I've seen is a lady who had a cancer that was actually older than me. But she had a cancer that was born, so to speak, in the mid 80s, had it resected, and I think had tamoxifen, because back in that day we didn't have anything else, and presented with a recurrence this year in 2022. So we're looking at 30, 35 years post, but it is a established phenomenon. And so the monarchy study was looking at adding abemaciclib, this oral CDK4/6 inhibitor, to standard aromatase inhibitor therapy, with or without ovarian suppression, depending on their menopausal status, and seeing if it could improve outcomes in women with early breast cancer. When we know that the CDK4/6 AI combination, this Batman and Robin, has really significantly improved things in the metastatic hormone receptor positive space. So it was. Fortunately, there will be none of the mental gymnastics and verbal gymnastics with this trial in terms of structure, in contrast to soft and text, because it was a quite bog standard open label randomized phase 3 trial. But it was a huge trial. It was international, over 5,500 patients in over 600 sites in 38 countries, which is a lot of data to get. Josh has his hand up.
I do. Now, my question to this, just for the listeners, is it normal to have trials this size, or is this probably one of the larger scale ones?
Yeah, I cannot honestly think of a trial off the top of my head. I'm sure there have been, but I can't think of an oncology trial that is more patients.
Yeah,
Um,
and my second question for you is, when we talk about the recurrence phenomenon, the distant recurrence of the 30 plus years, is it something people need to worry about? So, when you talk to a patient, you're like, look, we're giving you the adjuvant therapy, your risk of it coming back is really low. Should they be worried? Should they be like, look, I'm going to be that person that in 15 years' time, I'm going to get this cancer back?
that is a very good question, and one that really doesn't have a right answer, or it doesn't have a blanket right answer. I think that it is probably something that is important to mention, but at the same time, you do have to um, mention it in, I guess, an artful way. You shouldn't lie to a patient. Obviously, you should never lie to a patient. So if they ask you point blank, you should say it. But at the same time, you don't want them to come to the conclusion, and I have had this happen to me, where a patient has said, "Oh, what's the point then? What's the point of anything you're trying to give me?" I guess the way to phrase it, or a way to phrase it, would be that we are looking at a relatively low risk that is very much down the road. But the highest risk, and it's a fact of life that when you have high risk breast cancer, the highest risk is still in the first sort of 2 to 3 years after diagnosis and initial treatment. So it's one of those things that it's impossible to predict, but it's not really it's not really, there's not really a right way to say it.
No, but you exactly that. You said what I wanted to hear, which is it's rare. It's not a common thing. These drugs still work really effectively and really do reduce that risk. And convincing someone not to have the therapy significantly increases their risk of having that recurrence, whether that's at 5 years or at 15 years.
Yeah, and I guess they're more likely to have it at 2, 3, 4 years than 15 years. So I mean, the fact that the factoid that I started the podcast with, which is that most women are cured with early breast cancer, remains true even with this rare but adequately described phenomenon of late recurrence.
Michael's fun facts.
Yes. So, a monarchy, a huge trial with, I don't even know how many countries there are, but a significant proportion of countries on Earth were involved. There you go. Um, and it was comparing standard adjuvant endocrine therapy with an AI of some description, plus or minus abemaciclib. So it was open label, not blinded, because they didn't give a matching placebo. And it enrolled, what I like about this trial is it enrolled exclusively high risk cancers, or patients with high risk resected cancer. So the authors probably foresaw that if they included patients who had the whole gamut of cancers, so patients who had less than 5 millimeter cancers that would only otherwise be treated surgically, or node negative cancers, grade 1 to 2 cancers, that the magnitude of benefit with abemaciclib would be really low, if there was any magnitude of benefit found, because you're dealing with patients who are going to do exceptionally well regardless. So they defined high risk as patients had 4 or more positive lymph nodes after resection, or 3+ positive lymph nodes in addition to one of the following: a tumor size of greater than 50 millimeters, grade 3 histology, a key 67 of greater than or equal to 20%. So all markers of high risk disease that carries a high risk of recurrence.
And these are all pretty, they're scary numbers. Well, not, I don't know if scary is the right word, but when you're listening to histology of a breast cancer, something that's greater than 5 centimeters, or KI67 of greater than 20%, like these are something that you very much pay attention to.
Absolutely. So a tip for our younger trainees who are listening is, if you're going to your consultant and you've got all of the information to rattle off, the decision that you'll be most likely making in this situation is, at least in Australia, is, do I or do I not give this woman chemotherapy? And these are all the things that you need to look at: the size, the grade, the key 67, presence of lymphovascular invasion, and whether there are any nodes. So if you have that information ready, it'll help you and your consultant sort of come to a recommendation. Unsurprisingly, for this cohort, previous chemotherapy and radiotherapy was allowed, not required, which I guess speaks to the institutional variations in management of these sorts of cancers. And patients were allowed to have received up to 12 weeks of endocrine therapy before starting. Some of these patients did receive it sort of in the quote-unquote neoadjuvant setting, and we do see this sometimes in patients who have other medical problems, like they're waiting for another more critical surgery, and we just want to put them on something that is going to cause minimal toxicity, not interfere or worsen their existing medical comorbidities that are preventing them from going straight to surgery. But we also want to put something in that's going to, at very least, slow the breast cancer down. So we just pop them on endocrine therapy because it's generally much better tolerated than chemo, which I think I could say without fear of contradiction. So exclusion criteria were node negative breast cancer, metastatic disease, obviously it's an early breast cancer trial, or patients who had received previous endocrine therapy for cancer prevention, which I think is something that we see much less of these days, and also patients with inflammatory breast cancer, which, and I know we're saying this a lot, but is a completely different kettle of fish and probably a whole other podcast, were also excluded. Endpoints, Similar to soft and text, so the primary endpoint was invasive disease-free survival, which is defined as the time between the date of randomization to the first occurrence of disease recurrence or death from any cause. The secondary endpoint was distant relapse-free survival, so the time between randomization or distant recurrence. Overall survival, which we still don't have, because again, we're dealing with patients who do very, very well by our standards. Safety and patient-reported outcomes. The median age of the patients in the study, 51. 12.5% of patients were less than 40. So these are the patients that would have been included or had a significant survival benefit in the soft and text, the biggest survival benefit in soft and text trials. 60% of patients were eligible based on the basis of 4 nodes. So this is cancer that is not necessarily as aggressive as some other cancers, but has just potentially been allowed to progress longer, and so therefore has spread more extensively. 95% of the patients had received both radiotherapy, and 95% of the patients had received chemotherapy. Over half had received adjuvant chemotherapy. Almost 40% had received neoadjuvant chemotherapy, which is not the typical standard of care, but is sometimes used in patients who have really high risk disease, or disease where very large disease, very large primaries that we want to try and downstage. So it is done. And the most common chemotherapy, as was mentioned sort of at the top, is an anthracycline plus taxane. So this 6-month marathon of chemo. 68.3% of patients were given AI as first endocrine therapy. Generally speaking, I believe the patients who got tamoxifen were patients who had a contraindication to AI, because as we know from soft and text, tamoxifen is, only mildly improved by the presence of ovarian suppression, and it's probably not what you want to give for these patients who are demonstrably high risk. 14% of patients coming back to soft and text as well had AI with ovarian function suppression. So that roughly equates to the 12% of patients who are less than 40, with a small percentage of patients who are between 40 and approximately 50.
Yeah, so this means that people are actually looking at the data and using it. So that's great.
Yeah, no, it shows that. It shows how influential soft and text has been in terms of changing treatment modalities in patients who are premenopausal.
But I am keen to hear the results of this.
Well, I think you're going to get a sense of deja vu here, Josh, because the overall flavor, I will say, of the results of Monarchy is quite similar to soft and text, and quite similar to a lot of other trials in this space. So there was a statistically significant improvement in invasive DFS in the abemaciclib group versus endocrine therapy alone. The hazard ratio after 2 years was 0.75. 25% risk reduction, with a p-value of 0.01. The 2-year invasive disease-free survival rates were 92.2% versus 88.7%. So this is that 2 to 4% benefit range that we saw in soft and text. The improvement in distant recurrence-free survival was similar. The hazard ratio was 0.72, with the absolute numbers being at 2 years 93.6% in the abema group versus 90% in the ET alone group. So again, small numbers, but significant statistically and probably clinically if you've got a patient in front of you. Overall survival data, we have had only one update on Monarchy at this point, and I don't think we have the mature data yet. And again, similar to soft and text, this is probably not something that we're going to see for many, many years. You're looking at needing, and any of our more statistics-minded listeners will probably call me out on this, but I think you're looking at having sort of close to 50% of survival events before you can say that it is mature data. And if we're looking at a 90% disease-free survival rate at 2 or 3 years, then it's going to be a very, very slow trickle down to the point where overall survival data is mature.
Which is nice. It's a nice thing where there's a slow trickle.
It's a nice problem to have, definitely. But it's not something that we can probably wait for, because by the time, and this is the conundrum with these sorts of data, is we know that disease-free survival is not the ironclad outcome that it necessarily is, because we know that disease-free survival, and in the metastatic setting, its sister outcome, progression-free survival, you can have enormous benefits in these two areas and then simultaneously no overall survival benefit. But we just won't know that, and by the time we do, it's entirely possible that something else has come along.
I have a question. So you've got some early data. It's all very promising. We've got the 38-year-old, and you're like, oh, I could potentially do this. Um, my question is this: so if you're in that small cohort of patients who then recur, and you're looking at metastatic management, and abemaciclib is one of those drugs that you use in the metastatic sphere as a first line, so CDK4/6 inhibitor. Has there been data to look at re-challenging? Like, what's the sort of, what's the word on the ground for
I, I
this?
I don't know that anyone knows. I don't know that anyone knows, particularly in Australia, because this is not currently an indication. So we don't have the body of practical knowledge. I guess now I could never quite confirm this looking through the data, but I believe that the CDK4/6 was given for 2 years because there was mention of a 2-year treatment course. So I guess the question really is, did they progress on the CDK4/6, or call it sort of 3 to 6 months afterwards, where you could conceivably call it the disease refractory, or did they progress on the AI alone, assuming that I'm right and they only went for 2 years, or did you progress after the AI? Because if you progressed after the AI was stopped, or on the AI, there's evidence that changing an AI is like letrozole and anastrozole or exemestane to fulvestrant, on if you progress on the AI, there can be some benefit. You can add back the CDK4/6, because as far as we could tell, the CDK4/6 was keeping things at bay. The challenge, though, and I suspect what you were sort of getting at, is what happens if the patient recurs on the CDK4/6 and AI combination. And my guess would be that you would be. I don't think there's any evidence to say that you could change to another CDK4/6, because the word on the ground, or the thought on the ground, is that all of these are pretty much the same. Um, so you'd be looking at chemotherapy, I would have thought.
Yeah, so similar mechanisms between all the CDK4/6 inhibitors, and you're right. That's a good caveat to talk about. If you progress while on the CDK4/6, you can probably say mm, it's unlikely to
You can
work if
say
you
it's not
use.
working, definitely.
Yeah, but if you progress afterwards, the question is, I think it'd still be interesting to see if you re-challenge with it. Are you going to get a really good control? And you might. I think that's the thing. It'd be interesting to see if someone did a study looking at those that recurred after this, and then if you re-challenge, therefore, say like, would you have the same I guess volume of benefit versus if you'd never been exposed in the first place?
Yeah, and that is something that I guess we will know if this approach becomes more widely accepted, just through sort of post-marketing research and sort of I guess word on the street, as you said.
And what about toxicities? I'd love to hear if they're better than my softened text or if they're worse.
Well, I guess the most common side effect with abemaciclib is diarrhea, and this is something that I've been told, by physicians who have had more experience using abemaciclib, because of the three in Australia, at least, it does seem to be the one that has got the least market share. Palbociclib and ribociclib are much more commonly used, and I think up until recently, abemaciclib was only accessible through an access program. I think it might have made its way onto the PBS recently. So 97 or 98% of patients had an adverse event of any grade. The most common adverse event overall was diarrhea. 43% of patients had a grade 3 event, which was neutropenia, most commonly, I should say, and 2.5% had a grade 4 adverse event, which again most commonly was neutropenia. Others included fatigue, abdominal pain, nausea, anemia, arthralgia, and vomiting. But if you look at the CDK4/6s as a sort of family, each one has its own sort of quirk. So abemaciclib, I've been told, the thing that it causes more than its sisters is diarrhea. Ribociclib, for those who have used it, you'll know that the risk of cardiac arrhythmias, long QT syndrome is significant. And palbociclib doesn't really have a quirk, but one thing I have seen or heard of, I should say, is there is a risk of pulmonary toxicity with pulmonary fibrosis. So they each have their own sort of little thing, but that was sort of borne out. I guess the diarrhea component was borne out in this study.
Yeah, I think also with Pelbo, I find I like using it because I don't have to get an ECG beforehand. And if you want to start someone on, ribociclib, you have to do that. And I know it's not a huge thing, but it's just another step to add to what's already a very challenging situation for these patients.
But I guess it also comes back to patient selection as well. And there's been debate about because and this is very much getting off topic, but there's been in the metastatic setting a uh, definite survival benefit with ribo that hasn't been seen with palbo or abema. But at the same time, you'd be sort of playing with fire if you were giving it to a woman who had had 3 heart attacks, heart failure, and was on amiodarone for an arrhythmia. So it's
Yeah,
patient
and
selection.
yeah, that's it. And the other nice thing about ribo, if we're talking about both sides of the coin, is that you only need it for 3 weeks. So the cycles are slightly different from memory. You take a week off. So for those that would prefer not to have drugs every day, this could be an option for them.
Yeah, I think I did read that abema is actually continuous, so you don't have the week off that you do with ribo and palbo. Palbo has the week off. Um, so I guess conclusions, because we're very much getting off topic. Conclusions from monarchy is we told you that this is a huge area. It's very easy to get off track. Um, so there is a statistically significant benefit in invasive disease-free survival and distant recurrence-free survival with the addition of abemaciclib to endocrine therapy in high-risk disease. That's what the data say. It is statistically significant. It is numerically small, um, and the overall survival data is immature. So really, this comes down to the balance of benefit versus risk. And Josh, you said this before. It really does turn into a discussion with your patient. One of the breast specialists where I work, Professor Belinda Yeo, she always makes a big point of it being a discussion with the patient, because every patient will come at this from a slightly different angle, drawing on their own experiences, opinions, and what have you. Some will say, I have, for our patient, I have 2 young kids, I've got a high functioning job, I've got a lot of living that I want to do. So anything that you can give me that gives me a chance at a better outcome, I will take, and I will bear the burden of those decisions. Whereas others will say those side effects terrify me, and you're telling me that the absolute benefit is potentially quite small. I'm going to be a little bit more, I guess, for want of a better word, moderate in my, my or balanced in my approach to this, and say, I'm not going to benefit. I'm not going to risk the side effects of which you've lined out for me. So I don't think there's any right or wrong answer, because you are dealing with small benefits and potentially significant side effects, because the risk of neutropenia is significant as well. I think it really comes down to what the patient in front of you wants to do, and what they want to get out of their treatment.
And as we get closer to getting to the end and down the rabbit hole with Alice, um, I wanted to put that in. But as we're down the rabbit hole, and we've spoken a lot about 2 really great trials, things that all essentially offer benefit. I think that's something we can say, Mikey, is that,
Hmm.
my trial, soft and text, definite benefit using exemestane and ovarian suppression. But again, there's risks in that young cohort, and also in your trial as well, looking at, the addition of abemaciclib in the adjuvant, really
Hmm.
field, but also unanswered questions. That's a lot of oncology. And Michael, you hit it on the head. It's what's best for the patient at their current stage in their life and what would they be comfortable in managing. We can
Hmm.
manage toxicities, we can manage whatever people need, but everyone has a different requirement in life.
Yeah, and everyone has a different mindset, and I don't think anywhere is that seen, particularly in the oncology field. I don't think anywhere that the different mindsets are seen more starkly than in the field of breast cancer,
Yeah.
particularly early
And
breast cancer.
yeah, and you know what? 2% to the individual might not mean anything, but 2% to someone like a 38-year-old with two kids might.
Yeah, yeah, yeah. These are numbers. They're as cruel and cold as numbers can be, but they do mean different things to different people. One thing, and I think we'll just end on this note, to sort of look into the future, is one thing I'm very interested to see with both soft and text and with the CDK4/6 inhibitors is its effect on this phenomenon of late recurrence. Are we going to see that these late recurrences persist, and are these things that always will happen regardless of what we do at this stage, or are we going to see a significant decrease from more aggressive treatment? Because at the moment, a lot of these patients would just be getting tamoxifen. Many of them, we might be just coming out of the era where people didn't get chemo for high risk disease or got outdated chemotherapy regimens like CMF. So it will be interesting to see, and this is probably something that we'll again have to wait many, many years for. But will we be seeing an age where these late recurrences are much less of a factor?
Great way to end. Thank you for putting that so eloquently.
Well, I think it has been very much a rabbit hole, but thank you for coming on this journey with me, Josh. It's been great.
It's been a great 1 hour. Stay tuned for the millions more about breast cancer that I'm sure we can talk about.
We could be talking about breast cancer until the cows come home, but fear not for those of you who don't have a significant interest in it, because there is plenty more content in other areas of oncology to come. All right, I think we'll hold down there. Thank you very much, Josh,
Thanks
and
again. See you next time.
and we'll see you next time. Goodbye.